Welcome. Happy Friday to all those who celebrate. Welcome to our first clinical pathologic conference, CPC. This is one of my personal favorites conferences that we have during the year. We invite many of our expert clinicians and present them a fairly challenging case that they work through and share how they work through these issues and kind of share their thought process through it all. The part of the goal is to challenge them, see if they can get to the final diagnosis. But the real goal of this is to help them impart their approach to these problems, and you guys can take that away with you in your clinical journeys. So today we have the case of a 24-year-old male with past medical history of atrial fibrillation, presented with hypertension and dyspnea. Today we also have Dr. Eric Johnson here with us as our inaugural CPC discussant for the 2024-2025 academic year. Just very briefly about the history itself of CPC. CPC was actually originally started in Johns Hopkins and Harvard. You can see kind of these old pictures here over in the pit where they would have these discussions between expert clinician and these cases to learn more about how to approach these problems. In the early 20th century, Dr. George Dog brought here to WashU, where we have continued the tradition since then. Before we get started into the case itself, let's meet Dr. Eric Johnson. Dr. Johnson is one of our assistant professors here in the Division of Hospital Medicine. He did undergrad at St. Norbert College, then medical school in Wisconsin at the University of Wisconsin-Madison, and a residency in medicine just a little bit south of that in Iowa Hospitals and Marshfield Clinic and University.
For TV land, I want to bring your attention to New England Journal's clinical problem solving vignettes. Now, I realize they also have CPC as a regular thing, but I think that the flow of these more closely mimics what we're to do here in terms of again, delineating your thought process. Taking new information in stride, perhaps jettisoning, things that you thought maybe were present with new information coming in. So I kind of like this format a little better. So if any of you want to be up here doing this, or you just like solving problems, which I think is probably true for all of us, I would recommend it. Now, let's head to the case. So this case, really on the surface, when you look at it, like we see patients all the time with atrial fibrillation and hypertension. So you're like, not very exciting. Clearly, the part that's interesting is the fact that this is a very young patient. So that was, I think, the thing that stuck out for me and the most salient feature of this. And with that in mind, I think trying to parse this out is going to be contingent on figuring out exactly what we're working with. So between hypertension and atrial fibrillation, again, not a disease process we typically see in someone of this young age. With that in mind, I excerpted the next slide for the differential for secondary causes of hypertension. So more often than not, when we're managing patients who are in the 50s or 60s, we call this essential hypertension, meaning there's not really a single monogenic cause to explain it. There's environmental factors, there are genes that are involved in its pathogenesis. I won't get into that at this juncture. But I think in terms of trying to pick this case apart, I think we have to think about what things might be present in the patient and what things I'm going to want to know from a historical standpoint, as far as past medical history, family history, and then, looking at examination findings. So to that end, looking at this list, there's a whole lot of words here, but really it boils down to, as you might imagine, does this patient have intrinsic renal disease? Or do they have some other explanation for this? I don't think this is going to be a substance use type thing. It'd be kind of a boring CPC, but we're thinking about nonetheless. One thing that I found really intriguing is, again, if we want to invoke the concept that perhaps, again, Occam's razor, that perhaps the atrial fibrillation and the hypertension are due to the same entity, it really, in my mind, leads me to thinking about two possibilities. There are two of the conditions in here. So the first one I think about is thyroidal illness. So hyperthyroidism very commonly results in atrial fibrillation, and can result in elevated blood pressure. However, we usually don't make the diagnosis on biopsy. The second one that my mind automatically went to was pheochromocytoma. So that definitely can have cardiac manifestations, definitely can result in elevated blood pressure. So speaking expressly about this condition, I would worry, just in the back of my mind, I don't want to anchor on this, but I would think to myself, is there a familial history of conditions that might predispose to pheochromocytoma? Does the patient have any stigmata on examination that might suggest these? I'm talking about, thinking about neurofibromas, capillary spots, things associated with neurofibromatosis, NF1, which definitely has association with pheo. Asking about family history of malignancies, MEN2, AMB, and then, the other one I think about is VHL. All of these are actually inherited autosomal dominant. So worth asking family history.
Yeah.
So,
well, thank you for that initial evaluation. Like you said, the age is definitely the very interesting fact, given that we see, like you said, AFib, hypertension, dyspnea all the time, but it's the age that's really the factor that suggests something else may be going on than just more common things that we see in the hospital. So let me tell you a bit more about his HPI. So he started feeling ill about 1 day prior to presentation. It was characterized by an acute onset of shortness of breath and chest pain. He had some dyspnea initially on exertion, but quickly progressed to this dyspnea at rest. When he described the chest pain, he said it was diffuse, a burning pain throughout the chest, but didn't radiate, didn't go anywhere to his left arm or anywhere other place, or his back or anything like that. He also said that he's had some worsening headaches for a while, longer than that 1 day, some nausea, vomiting, epigastric pain. For all these reasons, he went to an outside hospital for further evaluation. Any questions or thoughts about that, this part? Or you can't mention you want to hear more about his entire history?
We'll need a little bit more, I think. Dyspnea has such a large differential diagnosis that it's going to be hard to necessarily, parse out what is underpinning it. So I might think about cardiovascular causes, knowing that this patient has a history of fibrillation, or just cardiac causes in general. But again, the risk is that you paint yourself into a corner, you lock onto it and you realize that was a red herring. So we'll want to hear a little bit more about things.
Okay. Okay. We'll go into the rest of it. I mean, not too much else about his HPI. We'll go to the rest of his history. In terms of his past medical history, he has a diagnosis of atrial fibrillation from a few months prior to presentation. He actually got a Holter monitor for workup from that. We are unclear exactly what the results of that Holter monitor was, but there was a Holter monitor that was ordered. No previous surgical history. In terms of his family history, his father had a history of hypertension, GERD, and OSA. His mother has a history of some undisclosed heart disease, and then his brother has some type of polycythemia. We're not unclear exactly what that means or what kind of polycythemia it is. He has no known allergies. He does not take any medications at the time. In terms of his social history, just drinks alcohol sometimes. And then he's currently a PhD student at that time, was a PhD student in biology at the University of Missouri. So I don't know, maybe the alcohol use is a bit higher than just socially, but
hard to tell.
It's hard to tell for those PhD students.
That is definitely something we have to think about for secondary causes of hypertension, that surreptitious heavy alcohol use can cause this.
Mm-hmm.
Makes for a pretty boring CPT though.
Yeah. Well, maybe that's the case. We don't know. We'll see.
Quick question for you.
Yes, sir.
Do we have any further information about this presentation 2 months prior, atrial fibrillation? Do we know what his blood pressures were running then? Were there any other abnormalities at that time?
Yeah. The question for those getting here was if we have any information about his what his vitals were and other information at the time of the diagnosis for his atrial fibrillation. Unfortunately, not. All that care was in a different system, and I think because he's at Mizzou, I know their system is not attached to ours. So the only information I could see was this initial hospitalization at the outside hospital, and then of course his the information we have here in our system too.
There are actually a lot of points relevant to that, in that not only you want to know what his blood pressure was at that time, but also, was there workup done for looking at, cardiac function, what was the ejection fraction, things like that. But I think we'll get into that as this evolves.
Yeah. On review systems, positive for some malaise and fatigue over the last day. I mentioned the headaches that have been going on actually for longer than just the last day. I think maybe for a few, kind of on off for a few weeks. He has the dyspnea, the chest pain, some palpitations, and he's actually noticed some lower extremity swelling in his legs. And then also mentioned the nausea, vomiting, and epigastric pain. Anything here that helps kind of direct you one way or another, including pertinent positives and pertinent negatives?
The palpitations may or may not be helpful here insofar as that we know that this individual carries a diagnosis of atrial fibrillation. But having said that, that doesn't automatically mean that the palpitations were due to that. It would be a second dysrhythmia, certainly possible. And that's something that hopefully we'll get a little further information. The lower extremity edema is interesting. To me, when I see that, it makes me wonder about a few things. One of the things that I think about, again, getting back to causes of secondary hypertension, would be the presence of underlying renal disease. So, for example, if a patient has pulmonary arthritis, for example, if, again, we talk about the nephritic pattern where you see blood pressure elevation, they don't typically have a lot of protein in the urine, but maybe part of it. So could that drive it? Conversely, the other thing I think about is, again, getting back to the heart. Is there anything going on with cardiac function that is resulting in the edema that might explain the dyspnea as well? So just something that we'll want to kind of file away in the back of our minds.
Yeah, sounds
The
great.
headaches, hard to tell what to make of that. I'm already clued into the fact that he's got this diagnosis of hypertension. Could it relate to markedly elevated blood pressure? Certainly. But also something we want to parse out further to see.
Yeah. Things to clarify, the diagnosis, from my understanding of reading through the chart, he doesn't have a diagnosis of hypertension when he presented, but as you'll see in a couple slides, he is hypertensive.
Correct.
So the only diagnosis he carried at presentation was the atrial fibrillation.
This is one of the joys of CPC, where I'm privy to some information that I know in the one-liner. So
yeah. Any additional thoughts in the history, total history, or ROS, anything like that you want to add on, or do you want to move on to the objective side?
The only other comment I have to make before we get to the objective is it's interesting that there is a family history of some sort of polycythemia. It's unclear as to how that relates to this patient's presentation. The differential for polycythemia is there are a few conditions that can cause it. Usually when you're thinking about erythrocytosis, usually we're thinking about, secondary causes, things related to hypoxemia, smoking, stuff like this. For what it's worth, I kind of think to myself that polycythemia, knowing that the hypoxia-inducible factors are associated with pheochromocytoma in particular, and that's part of the pathogenesis of why the syndrome associated with pheo are associated with it. I have to wonder if there's any relationship there.
Interesting.
We can leave it for future, but
sure, great. We're going to go into the physical exam. What are some of the things you're going to be looking out for when you approach this patient on physical exam?
Very good question. So first and foremost, we're definitely going to see what the blood pressure is, what the heart rate is the heart regular? So looking at vitals, the general appearance, I'm going to want to know, does this person look anxious? Is there anything unusual from a psychologic or psychiatric standpoint? Are they anxious appearing? I mentioned thyroidal disease, so a good thyroid exam, looking for evidence of thyroid enlargement, looking for, does someone have a fine tremor that might suggest hyperthyroidism, their cardiac exam, is there an S3, is the ventricular venous pressure elevated? Again, trying to objectively know, do they have edema, and if so, how much? And then, lung exam, just to make sure we don't miss anything, looking for evidence of Rawls or, other things that might suggest where the dyspnea, what's causing the dyspnea.
Great. All right, let's see if we can answer some of those questions. So physical exam, we'll start with the vitals. He came in about blood pressure is 165/89. His mildly tachycardic to 104. At this time, he was breathing 23 times a minute, setting 99% room air, and his temperature is actually normal. However, Clinical update. So instead of getting the rest of the exam, he became acutely tachycardic and found to be in VTach on EKG. They gave him some amio and converted to normal sinus rhythm after that. And then when they repeat EKG after he converted, they showed some diffuse ST depressions at that time. Shortly afterwards, he then began to desat to 78% and was placed on non-rebreather with improvement in his oxygenation to 86%. Concern for some kind of intrathoracic issue. They took him to CD for further evaluation. However, he then vomited and on the scanner and was intubated for airway protection prior to completion of any imaging. It gets better. He was then admitted to ICU where he went to PA arrest 3 times. He quickly progressed, requiring high dose of triple pressors. And they bedside echo showed severe LV dysfunction, a stress-induced cardiomyopathy pattern. And they took him to the cath lab to place an Impella, which they did. However, he still required very high dose suppressors on the Impella, and they transferred him to Barnes for ECMO. When he gets here to the CTICU, the Impella waveforms are lost. When they transferred him over from like the stretcher to the bed, reinitiate CPR, and he was cannulated for VAA ECMO. Welcome to CPC, guys. So these are his vitals after cannulation. Now ROSC is achieved, and the exam performed by the CTICU team. So at this time, his blood pressure is 126/93. Heart rate is still tachycardic at 111. Respiratory rate is 24, and he's actually febrile now at 38.4. Most of the exam is obviously limited given the fact that he's intubated and sedated. His lungs are otherwise clear to auscultation. He is a little bit tachycardic. I'm sorry I didn't make that red, but otherwise regular rhythm. He has his cannulas for VA ECMO in the left and right groin and some trace bilateral lower extremity edema. Otherwise, the rest of the exam is unremarkable. Thoughts?
My first thought is that PEA sucks. So very clearly there is something that is involving the heart that we need to take in stock as well, which again kind of confirms our initial suspicion that perhaps the same explanation for the fibrillation is underpinning elevated blood pressure. His examination right now doesn't give any major clues that I see. Thankfully, his blood pressure is in the normal range, but this is while on pressors.
On pressors and on ECMO. I'm not too sure how to manage ECMO, but presumably that's doing a lot of heavy lifting for making sure he's perfused.
Right. So that's not going to give us a whole lot of clues because a lot of that's superficial. What can give us some clues is if we go back a slide or two.
This one or this one?
That one. There's a couple things that are very interesting here. So the fact that this patient went into ventricular tachycardia, to me, also underscores the possibility that we have some sort of cardiomyopathy present, okay, which we are finally clued into when we get into the bedside echo. And I'll comment on that a little bit more. The fact that he desaturates rapidly, to me, makes me wonder whether or not he had pulmonary edema as the explanation for the hypoxemia, because that would come on very rapidly. So again, probably related to severe cardiomyopathy. Now, there's 2 things that I find quite interesting: the diffuse ST segment depressions and the stress-induced cardiomyopathy pattern. Those 2 things, when I hear that, make me wonder about so-called Takotsubo cardiomyopathy. So the octopus pot, right? So, or what when this first came out, April Bloom syndrome. There is an association between Takotsubo cardiomyopathy and pheochromocytoma as well. Mm-hmm. So just my initial thoughts thinking about this case that, perhaps this is what we're dealing with. Again, right. We still need much more info.
Right. I mean, obviously he became very sick very quickly, and that can help key us into some possible etiology. So, going through here and here, what diagnostics do you want first? Remember that. And then for our people who are joining us for the first time, this is a pick your own adventure situation. So as Dr. Johnson calls out specific things that he wants, I will select the option and go from there. So what would you like to start off with for your diagnostics?
I'm kind of boring, so I'm going to go with just the general basic stuff. So let's get a sense for what this patient's renal function looks like, their electrolytes, et cetera.
Okay. So we'll start with the BNP and CBC, his initial lab. So again, this is on presentation to Barnes when he has already suffered 4 cardiac arrests. So his creatinine is elevated to 2.91, but the rest of his, and his glucose is a little bit elevated, but the rest of his BNP is within normal limits. In terms of his CMP, you can see his AST is and ALT are highly elevated. And he has a little bit of an elevated T-billy and D-billy as well. And the protein albumin are a bit low. Thoughts?
Not particularly helpful in terms of boosting a diagnosis insofar as that, as you mentioned, this patient had 4 separate cardiac arrests.
Correct.
Was on pressors. So I would hazard that the elevated creatinine and the AST and ALT probably are due to ischemia. Yeah. So we have a shock liver pattern, plus, perhaps this patient developed ATM. Cool. So I don't know that it's going to give us a lot of clues to figure out the ultimate diagnosis, but at least tell us where we're at right now.
Gotcha. And we also have a CBC. White count's elevated at 28.8. Hemoglobin's a little bit low, 12.3. We do not actually have a differential with this.
And again, acute stress response can be a little tough to tell. Who knows if he had gotten corticosteroids along the way, sometimes that happens, but the stress response itself in someone who is fixing to die could easily jack that white cell count. It is fair to think about the fact that he was febrile. So we should always keep in mind, could this patient have a bloodstream infection or similar? Be a little hard to find a unifying diagnosis, but you don't want to take that information and just throw it aside just because it doesn't fit your thought process. So also something we're going to be looking at.
Gotcha. So what I'm taking away from your interpretation is a lot of this may be more secondary to his arrests rather than a primary process related to whatever started this in the first place.
That's my supposition, but again, in the interest of trying to make sure that we don't allow this patient to die, I think it'll be very important to just, get blood cultures, ensure we're not dealing with some kind of overwhelming infection.
Yeah. You want to check out his infectious workup then?
Sure.
Cool. Oops, that's the wrong one. Don't do that. That's wrong. See, I have to learn how all the buttons. Which one? No, that's radiology. Wait, I thought that was. Oh, duh, it's the virus. It's the virus, Edward. That's the infectious workup. So, infectious workup, blood cultures, RVP.
Kind of like the COVID-y look to it.
Yeah, exactly.
I was going to pick it for that reason alone.
Yeah, urine culture and then the acute HEP panel were all negative.
Okay.
Anything you want to comment?
Not really.
Fair enough.
I feel a little bit better that I'm not missing something.
Okay. What would you like next based off of this?
I would like to have found out why this patient had desaturated, and maybe now with ECMO in place and maybe with volume status improved, maybe the chest X-ray was a little different, but it would be nice to see why this patient desaturated so abruptly.
Okay. I don't think we actually got we don't have a chest X-ray here, but it did show some kind of diffuse infiltrates bilaterally. Okay.
That's good enough for me. So it does fit with our thoughts that perhaps pulmonary edema is driving that.
Okay.
With that in mind, I don't know whether I would worry about getting an NT-proBNP or if I would just simply go to get a formal echo. To be honest, since we already know this patient's EF was diminished, I think a formal echo is going to be very useful here.
Okay. So we'll get a formal echo. Again, this is, after being here, his EF was actually normal on this echo here at Barnes. But they showed akinesis of the mid-inferior wall, hypokinesis of the basal inferior and mid-inferior lateral walls. And otherwise, he had the ECMO running at 3,800 RPM at 3.8 liters per minute, whatever that means.
Makes it a little hard to interpret.
Yeah.
And we probably don't have any older echo information to work with.
Unfortunately not.
Okay. All right.
So where do you go from here? Obviously he had a lot of history of in the stress-induced cardiomyopathy that was reported to us from the outside hospital with severe LV dysfunction of the bedside echo, but our echo is actually normal. Where do you want to go from here to help figure out what may be going on with the gentleman?
Very good question. It'd be unusual for this patient to have cardiovascular disease, atherosclerotic disease driving this, but certainly with focal wall motion abnormalities, we're thinking about the possibility of such. At the same time, I don't know that I would necessarily feel comfortable dumping contrast into a patient like this to look at his vasculature. So I think probably for next steps, what I probably would advocate doing is, again, noting that there was a stress pattern at the time before they had ECMO going, I might try to focus on that to kind of figure out, what might be driving it, because again, that pattern really makes me wonder whether or not this was indeed a Takotsubo-like pattern.
So how would you like to pursue that further?
All right. Probably what I would do. I'm trying to think of how to do this properly so I don't just simply jump to an assumption. Because it never looks good,
Fair.
right?
Yeah.
Just because we are going to be a bit limited in terms of looking at other things. Let's see, what are other options?
So other options we have, we can look at some urine studies. You can get some other blood work. We do have some other imaging studies, depending on which one that you request. And I actually think that's most of the, and then some anemia workup as well. I think that's actually most of it.
Okay. Yeah, I think in this case, again, we know that he's not hypertensive at this point, but again, we have the PEA arrests. This is episodic in nature. I mentioned the possibility of underlying toxic cardiomyopathy. If I'm going to kind of hone in on one thing, it's going to be trying to exclude pheochromocytoma just because of the pattern. I just don't want to, be too confined
focused on
with
that
one thing.
Okay.
But if it were me, what I'd be thinking about is doing plasmapheresis as an assay. I don't know that imaging from the get-go right now without having confirmation that there's a hypercatechol allergic state, I think you're putting the cart before the horse.
Okay.
But at the same time, it will ultimately be part of the workout.
So you would like some plasmapheresis?
Yeah, I think, again, if I'm operating based on that bedside echo, which I know, there's always risks to doing, but noting that this patient had episodic hypertension, plus have this stress-induced cardiomyopathy, I want to make sure that's not missed as an underlying cause.
Okay. So we did get some other lab work. ECO and endocrine lab work here is mostly normal. Testosterone is a little bit low at 59. I think normal is about 70 or so. They did get metanephrines and norepinephrines, plasmapheresis. Those are highly elevated, 14 and 66. Those are the normal ranges next to it.
Okay. The testosterone as a single measurement,
correct.
I'm not sure we can read a whole lot into that because obviously diagnosed hypogonadism, you want a repeat measurement. Patient's acutely ill, probably has some, suppression of some central suppression. So I'm not too worried about that. But these are quite interesting. So I think next steps, if you're concerned about it, next steps would be to get abdominal imaging dedicated to the adrenals.
Okay, sounds great. And we have Dr. Katerina Konstantinov here from his professor of radiology, who will now explain some of the imaging we got. You just go here, and let me do. Here's a laser pointer, and then use the arrows to navigate.
All right, so what are we seeing here? Okay, so can you hear me? Oh, can you hear me better now? All right, so this patient got a CT of the abdomen without contrast, and then a CT chest, abdomen, pelvis with contrast when he got here. A few things, we already know this patient is quite sick, but we see a lot of findings of that on his imaging. So in his lungs, he has severe pulmonary edema. This is one of his ECMO cannula in the IVC. And notably on this non-contrast portion of the scan, what you notice, there's no contrast in the vessels, which is how we know that it's non-contrast, but the kidney is really bright. So that means that he, when he was at the outside hospital, it sounds like they didn't complete the scan, but I guess they injected the contrast and it's still hanging out in the kidney, which is indicative of, basically ATN or impaired renal function. So he has a persistent nephrogram here, which a little bit limits the interpretation of the multi-phase CT, because there's still contrast hanging out in the kidney. There may still be retained contrast elsewhere as well. And when we look at the adrenals, what we like to do is, compare enhancement patterns. to better characterize a mass. And I think the thing that we haven't talked about yet is there's a large adrenal mass here on the right.
That's a difference from one side to the other.
Yeah. So there's this, round, at least 7 centimeter, I think it measured, right adrenal mass. And then, the CT wasn't definitive in characterizing it because of some of those limitations that we talked about. On the non-contrast portion, this component was not enhancing, but it was high density, which suggested kind of either a complex cystic component or a hemorrhagic component. There was this part laterally, which was sort of equivocal. We look for a difference of 20 Hounsfield units in saying something is definitively enhancing. So maybe there's a solid enhancing component, but ultimately we had this large right adrenal mass, which was partially likely hemorrhagic. It's not definitive, but it could be some sort of adrenal hemorrhage, a mass that has hemorrhage, possibly a PHO, but it wasn't that diagnostic.
The notation of the high Hounsfield units does lend support towards this possibly being a PHO.
That is true.
And between when you say hemorrhagic and you say cystic, my mind goes in the same direction. So I would be suspicious about that possibility.
Awesome. Thank you, Dr. Konstantinov, for that. It's very informative. Anything else you would like? You want a sample of that tissue? Do you want to check?
We ultimately are going to do that, but we're not going to be doing that right in the here and now.
True.
So
why is that?
Because I have to wonder whether, in fact, that thought crossed my mind when you were mentioning the exam, when this patient went into VT, was this immediately following abdominal palpation?
It's a good point. I don't know. This is from the outside hospital. I'm not too sure.
Let's not redo that. So
Sure.
in other words, in this case, we need to pre-medicate if you're going to be thinking about any sort of sampling because of the risk of stirring that hornet's nest up.
Okay. What kind of pre-medication would you give him in this case?
I am talking expressly about alpha blockade. Insofar as that, obviously you got to tamp that down to avoid hypertensive crisis cases.
Yeah, great. So we got him, just to summarize, alpha blockaded.
Okay.
And he is ready for surgery to take it out. And so now we have, is this the right? No, it's the path. That's the pathology. So now we have Dr. Jason Sina here, who's a fellow in GU and renal pathology. They got it out. They put in their slides, and Dr. Sina here will explain what is seen on the slides.
So what we got is So we got about 7 cm well circumscribed mass. The mass, as you see here, has a capsule, and it's a very well vascularized. As you see here, they're all vessels, and these are all red blood cells. And the mass is a kind of eosinophilic look to it, and these are all nest of the mast with a very delicate vasculature between them. And this is one single foci that you see the mass is invading the capsule and going outside. Higher magnification, again, kind of relatively monotonous look to the mass, tumor cells with very delicate vessels between them. High magnification, so it shows abundant granular eosinophilic cytoplasm. NC, nuclear cytoplasm ratio is preserved. Nuclei showing oval to round with kind of so-called salt pepper granular chromatin to it, very classic for a neuroendocrine tumor. And we did some immunohistochemical stains, and the mass is strongly positive for synaptophysin and chromogranin, negative for CK7, which rules out neuroendocrine carcinoma. And Ki-67 proliferation index is low, less than 1%. And based on these findings, this is a pheochromocytoma, 6.7 cm.
Thank you very much, Dr. Sina, for that. And then I think we're probably now safe to go to the diagnosis slide, sir.
I think so.
And your diagnosis is?
My diagnosis, not only am I going to say pheochromocytoma, but I have to wonder with the familial, the family history of polycythemia. And I was going to mention this earlier, but again, I didn't want to. I think it's HIF, is it 2 alpha? EPAS1 has actually been associated with both pheo and polycythemia, if I recall correctly. So I'm wondering whether
I would trust you for that.
I'm wondering whether that, yeah, but it's pheo.
Yes. So great job. Yes. Pheochromocytoma. Which you called out from the beginning. So I had to make sure I kept a straight face the entire time. So obviously the data presented is not exactly how his hospital course went. When he got here, he actually got that CT pretty quickly and they saw that mass. And so after identification, they switched his pressor to nicardipine, doxazosin, and milrinone, which I think the milrinone is actually for the ECMO. But with pretty rapid improvement in his cardiac function, where he actually got decannulated from ECMO within 3 days after that. Pretty soon, he was then transferred to Cardsperm. He started on carvedilol for beta blockade. Then he got the laparoscopic adrenalectomy with MIS, that no complications. Then we saw pathology confirming it. While he was in the hospital, though, he was there for, I think, about 6 weeks total, if I remember correctly. He had it was complicated by a hypoxemic respiratory failure, so he actually was intubated for a bit longer than ideal. And then he did require renal replacement therapy for a total of 2 months, including a little bit outside of outpatient after that. However, now he's doing well. He just takes some doxazosin, keeps things under control. He sees endocrine and nephrology because after the hit he had to his kidneys, he has a little bit of CKD from that. A little bit about pheochromocytoma. So they're a type of catecholamine secreting tumors that rise from the chromaffin cells of the adrenal medulla and sympathetic ganglia. They're actually fairly rare. It's about incidence is about 0.8 per 100,000 person years. And one thing I thought that was interesting is that in terms of secondary hypertension workup, I know that in our clinic, we can always consider getting plasma metanephrines. However, pheo is only present in less than 0.2% patients with hypertension. Now, this is all patients with hypertension, not those that we would start initiating a secondary hyper workup for resistant hypertension. The classic triad of symptoms is episodic headache, sweating, and tachycardia. However, most don't present with this. Other signs that were present in our patient was the paroxysmal hypertension, palpitations, dyspnea, and other things also include tremors and panic attack type symptoms, things that you've probably heard about before. What you correctly called out was can rarely lead to a stress-induced cardiomyopathy, which is exactly what happened to our patient. And then to diagnose it, you want to get plasma metanephrines, 24-hour urine metanephrines, and catecholamines and imaging. They didn't get the urine metanephrines in this case mostly because everything was so consistent with it. They didn't see a need to get the 24 hours. Also, about 10% of cases can present as metastatic disease. So it's actually not that uncommon for it to be metastatic if found. In terms of treatment, resection of the mass is generally curative. However, beforehand, you need adequate alpha and beta blockade. You always start alpha blockade before beta blockade to avoid that unopposed alpha activity linked to hypertension. And so at least what the recommendations are about 7 days of adequate alpha blockade and then 2 or 3 days of adequate beta blockade defined by blood pressure goals as well as heart rate goals. And they usually use doxazosin, which is what our patient had on. And then go in and take the entire thing out. For metastatic disease, it's a lot more complicated that I didn't want to get into because that's definitely a very specialized oncology decision there. And actually, it can recur. About 3 to 60% have some degree of recurrence. Even decades later, there is one case report having it recur like 50 years after the fact. So any parting thoughts on this case after seeing it all?
Again, I think the only thing I would add, I think it's pretty clear case of pheo. For me, the fact that this came on early really makes me worry about a familial type of, like a genetic predisposition to the condition. More often than not, usually we're thinking about, neurofibromatosis 1 or, von Hippel-Lindau or, the third one, I think, now I'm blanking. I should know it's offhand. Or NEN2. Yeah, wake up. But having said that, none of these were mentioned that suggest that still that doesn't obviate the possibility that there's some sort of familial dependency. I really have to wonder about that polycythemia diagnosis. And that was a sibling?
Yes, his brother.
Okay.
So, great. Well, thank you so much, Dr. Johnson. Really appreciate your discussion. It was fantastic. So you're thinking